My name is Tina Oteng, and I'm going to give a brief overview of the brachial plexus. In this overview, I will review the relevant anatomy of the upper limb. I will define the brachial plexus. I'll demonstrate the components of the brachial plexus and describe the complications of brachial plexus injury. The upper limb consists of very many muscles, both in the anterior compartment, as shown in this slide, and the posterior compartment. Please note that I have not included the small muscles of the hand, which increase the number further. Let's define the brachial plexus. It's a group or network of branching nerves that control the upper limb, meaning they provide both motor and sensory input to the numerous muscles of the upper limb, as well as the skin covering the upper limb. The brachial plexus arises in the neck at the vertebra. The nerve roots then combine in different formations, passing under the clavicle and access the upper limb through the axillary space, which is commonly known as the armpit. We'll now look in more detail at the structure of the brachial plexus. The brachial plexus is formed by the roots of the 5th, 6th, 7th, and 8th cervical nerves and the 1st thoracic nerve. These form the roots of the brachial plexus. The 5 roots combine to form 3 trunks of the brachial plexus: the upper, middle, and lower. So up to this point, it's useful to use the analogy of a tree having roots and trunks. Each of the trunks divides into 2 divisions, an anterior and posterior division. There are therefore 6 divisions of the brachial plexus. These divisions combine to form 3 chords of the brachial plexus: the lateral, posterior, and medial chord. The chords are named as such with respect to their relationship to the axillary artery, which passes through the space between the chords. From the 3 chords, we get the 5 terminal branches or peripheral nerves. These are the musculocutaneous nerve, the axillary nerve, the radial nerve, median nerve, and ulnar nerve. Here we have a detailed list of all of the nerves supplied by each of the terminal branches of the brachial plexus. It's beyond the scope of this brief overview to go into the details of each of the muscles supplied, but you have the table for your future reference. The brachial plexus also provides sensory input to the upper limb. This can clearly be seen when we consider the dermatomes of the upper limb. The dermatomes simply refer to the pattern that a spinal nerve root takes as represented by the sensory innervation on the skin. And so we can see, for example, with the components of the brachial plexus beginning at C5, we can see that that runs in a strip along the front of the chest and all the way down the front of the arm. Let's consider some applied anatomy at this point and talk about brachial plexus injuries in a little bit of detail. As we have seen, the brachial plexus begins in the neck at the cervical and thoracic vertebra with its roots. Injuries at the level of the root, so high up in the neck, give rise to very characteristic injuries. If the upper two roots are injured, that is C5 and C6, the resulting injury is called a Bell's palsy. This injury is characterized by an extended upper limb with the hand cupped backwards, almost as if asking for a tip. So sometimes you might hear it called the waiter's tip palsy. Erb's palsy is very common in very young babies as a result of birth injuries, but it can also occur in contact sports where there's a sharp downward force on the shoulder stretching the neck away from the upper limb. The second type of injury at the root level is called a Klumpke's palsy. Klumpke's palsy is less common than Erb's palsy, but it's also associated with birth injuries. This particular palsy tends to affect the lower roots of the brachial plexus, so C8 and T1. Depending on the severity of the nerve injury, the child may go on to recover fully or may be debilitated with this nerve palsy for life. The next injury to consider is a median nerve injury. The median nerve goes on to supply all of the small muscles of the hand and some of the skin overlying the hand. When it enters the hand at the wrist, it occupies a fairly superficial position in a fibro-osseous canal. This space can become inflamed, causing the nerve to be compressed in what's commonly known as carpal tunnel syndrome. This results in loss of the pincer grip, which is the opposition of thumb to individual fingers. If the injury is long-standing, the result is wasting of the small muscles that are innervated by the median nerve, as can be seen in this picture. The other type of injury that the median nerve is susceptible to is a traumatic laceration at the wrist, again as a result of its very superficial position at the wrist. The ulnar nerve supplies some of the small muscles of the hands and is a particularly long nerve running pretty much the length of the arm. At the level of the elbow, it runs a very superficial course in a groove that lies behind the medial epicondyle. Indeed, when you bang your elbow and you get that tingling sensation in your arm, it's the ulnar nerve that's been traumatized. This is why it's sometimes called your funny bone. But when more serious injuries are sustained further down the course of the nerve, you get a characteristic deformity called a claw hand, in which the first and second fingers are unable to fully extend. The radial nerve supplies the muscles of the posterior compartment of the arm. This includes the extensor compartment of the arm. In the upper part of the arm, the radial nerve runs through the spiral groove along the length of the humerus. Fractures at this point can cause injury to the radial nerve and a resultant wrist drop. Higher up in its course, at the level of the axilla, the nerve is also susceptible to compression. For example, with poorly placed crutches, or in the infamous Saturday night palsy, in which an intoxicated person falls asleep with their arm hanging over the back of a chair. The axillary nerve supplies mainly the muscles around the shoulder, the deltoid, and some of the rotator cuff muscles. It also supplies sensory innervation to a patch of skin over the lower half of the deltoid. This area is referred to as the regimental badge area. The axillary nerve wraps around the surgical neck of the humerus, and in cases of shoulder dislocation, the nerve may become stretched, giving rise to anesthesia or loss of sensation in the regimental badge area. The last nerve to consider of the brachial plexus is the muscular cutaneous nerve, which supplies the biceps and the brachialis, and also part of the skin of the forearm. This nerve is not usually involved in any brachial plexus injuries. Thank you for your attention.